These are my financial disclosures. You can see that I have trouble saying no to being a consultant, but I do not accept any personal remuneration from any pharmaceutical or device company. So my job here is to lay the foundation for the more detailed discussions that you'll be having later in the day. What is inflammation? Well, from the origin of the word, it comes from the Latin to burn. And what's interesting is that the ancients, with simple powers of observation, with their six senses, and having less distraction, no internet, no email, they were able to make a great deal of inroads into understanding pathophysiology. And it was Cornelius Celsus who, in the 1st century AD, predicated the criteria for inflammation that we teach our students today. In Latin, it was rubor, tumor, calor, dolor. And for most people in the room, you don't need a translation, but when I give this talk in the United States, no one's been through classical education anymore. So it's redness, swelling, heat, and pain. And it was Rudolf Virchow, the great German pathologist and public health advocate, who added lesio functione, or loss of function, in the 19th century. And to understand inflammation, we like to think of inflammation in two arms. The innate immunity, which is very old phylogenetically. Horseshoe crabs have innate immunity. And it's very fast and it's blunt. It recognizes thousands of structures, whereas the adaptive immune system arose much more recently in evolution. It can recognize billions of different structures. It requires maturation in order to achieve its highest degree of specificity. And it is really very much cemented in the idea of complementarity. Now, I teach in the Harvard Medical School course for graduate students in immunology, Immunology 202. And I'm going to give you in the next few minutes a condensed version of what we discuss in this graduate course of immunology. And then the subsequent speakers will fill in the much more clinically relevant details. So the father of innate immunity was Mechnikov, who was Russian and French, and he vacationed during the summer in Messina, and he noted that marine invertebrates would engulf foreign materials, such as a rose thorn, and he really developed the idea of phagocytosis and is regarded as the father of innate immunity. On the other hand, working in Germany, Paul Ehrlich and his loyal assistant shown there really was instrumental in developing some of the concepts of adaptive immunity. He understood about antibody. He didn't call it antibody, he didn't know what it was, but he knew that he was able to transfer immunity in serum. And the clinical problem that he was attacking, one of them was diphtheria. And he also developed theoretically the construct of complementarity, of the key and lock. What we call a hapten today, he called the side chain theory, because this is at the time that in Germany, organic chemistry was the queen of all sciences. So interestingly, these two individuals, the father of innate immunity and of adaptive immunity, were recognized in one of the very early Nobel Prizes in 1908 in recognition of their work on immunity. And all we've done in the ensuing century is fill in some of the dots of what they thought of in their really pioneering thinking and observations. So what are the messengers that mediate and modulate inflammatory mechanisms? There are cytokines, which are protein mediators of inflammation and immunity, and a subcategory are chemokines, which are involved in chemoattraction and trying to keep leukocytes at the place where they're needed in pathophysiologic reactions. There are lipid mediators, and there are many, many of them. Eicosanoids are very well known. The prostaglandins, for example, the lipoxins. It's oxidative stress, They're reactive oxygen species and free radicals. And then there's the other side, which has really been championed by my colleague at Harvard and the Brigham and Women's Hospital, Charles Sirhan, who has described the resolvins and the maricins, which are not anti-inflammatory because they don't suppress immunity, but they promote resolution. And their role in pathophysiology is a matter of continuing interest. Now, what are the cells that mediate and modulate these inflammatory mechanisms? Well, the cells of the innate immune response are the macrophages, and that's what Elia Mechnikov discovered when he was on vacation in Messina observing the marine invertebrates. And then there are the cells of the adaptive immune response that really came to the fore in the middle of the last century, the T and B lymphocytes. And then there are the tissue cells, the parenchymal cells, that react to the mediators that are elicited from these cells. There are epithelial cells, and of course my favorite epithelial cell is the endothelial cell, but as we'll see in a moment, this applies broadly to a wide variety of diseases and organs. And then there's mesenchymal cells, many cell types that go together with an epithelial cell to make chronic diseases. So this is the syllabus of Immunology 202 at the Harvard Medical School, and you get it for free in 1 minute. Okay? The point here is that there's a lot of crosstalk between innate and adaptive immunity. I'm sorry that some of these slides are cut off. This is a Mac to PC problem. Okay? And the point here, I'm not going to go through it in detail, and you can certainly look at the reference, which is cut off there, but I'm happy to supply it. It's probably in your handout. We have mediators that are elicited from the adaptive immune cells of various types, and they're usually activating stimuli, but there are also some brakes on inflammation. For example, the regulatory T cells, the Tregs, can secrete some anti-inflammatory mediators, whereas, say, the Th1 cells will be elaborating pro-inflammatory mediators, and of course the B cells are making antibody. Most antibodies are actually thought to be pro-inflammatory, but there are anti-inflammatory antibodies as well, which we can go into in discussion. And then the products of these cells, the conversation between the cells of the adaptive and innate immune response impinge on our favorite epithelial or epithelial or mesenchymal cell and give rise to the diseases that bring us here together. So the message that I have here is that inflammation is much broader than mere cardiovascular disease. Of course, every organ has vessels and microvessels, and I think from my perspective as a vascular biologist that vascular biology is important in all organs. But here, way back in 2004, the cover of Time magazine suggested that inflammation is involved not just in myocardial infarction or atherosclerotic disease, but also in cancer, in dementing illnesses, and other diseases. And of course, what we're here to do together is to figure out how to take the science of inflammation and apply it to our patients for their betterment. So here again is the generic chronic inflammatory disease. So here's the T cell committee, signals from the Th1 cells and Th2 cells, and of course all of the subdivisions. And now, in the era of single cell genomics, we're able to look at the transcriptional profile of individual cells, and as I've quipped in the limit, every cell is its own cell type, which is probably true, but it's not very helpful. So we still use as anchors some of these older categories like M1, M2 macrophages and Th1, Th2 T cells. They impinge on the cells of the innate immune response, which are usually more numerous than the T cells in the tissues. And they elicit from the epithelial cell or the mesenchymal cell a rather stereotyped series of responses, which, if you think about it, are at the root of many, many diseases in many different organ systems. It's proliferation of cells, or its opposite, death of cells, fibrosis, extracellular matrix synthesis and accumulation, leukocyte recruitment to sites of injury or infection, and angiogenesis, which is required often for repair of tissues. And what we call the epithelial cell or the mesenchymal cell depends on what floor of the research building our laboratory is on. If we're in the cardiology section, we're concerned with the endothelial cell and the smooth muscle cell. If we're in the gastroenterology department, we think of the enterocyte. If we're in the kidney department, we think it's the glomerular epithelial cell, endothelial cell. If we're a pulmonary doctor, a lung doctor, we think of bronchoalveolar cells interacting with synoviocytes. And of course, the mesangial cell is the nephrologist's favorite mesenchymal cell. So the same, it's sort of like, Vivaldi wrote 400 concerti, but they sound a lot alike, So we have diseases, 400 diseases, but the fundamental mechanisms are very common and are shared, and inflammation is often the driver. And then there's the aspect of the interaction of non-vascular diseases with vascular disease. And there's what I call the echo phenomenon, which is the diseases with inflammation that are remote from the blood vessel can impinge on the prepared soil of a nascent atherosclerotic plaque. I'm sorry to tell you in this audience, you're all young, but if we did carotid imaging or CT imaging or intravascular imaging of many of you, you would have nascent atherosclerotic plaques. We know that from the P-Day study, from the Bogalusa heart study, and others. So you have the prepared soil in the intima of some accumulation of inflammatory cells, and when you have remote inflammation, as depicted here by an inflamed synovium, it releases cytokines that can again elicit an echo from the cells lying in wait, perhaps in a steady state, that can make a round of activation of these cells and promote those stereotyped responses that we discussed. And of course, there's also metabolic effects of some of these cytokines. TNF-alpha can cause insulin resistance. We can have adipose tissue teeming with leukocytes, again, that can be activated by remote sites of inflammation. And of course, these mediators, particularly IL-6, which is downstream of IL-1, as we'll show in a moment, can elicit the acute phase response from hepatocytes that lead to the overproduction of fibrinogen, the precursor of clots, and plasminogen activator inhibitor 1, which is our major blocker of our endogenous fibrinolytic clot-busting system. So you can see how there's interaction between remote inflammation and the cardiovascular system. And that's very important to keep in mind, because we're going to be hearing about C-reactive protein later. And people say, well, C-reactive protein is nonspecific. Well, that's why it works, because it can pick up inflammation at remote sites. It might be in the gingiva in one patient with periodontal disease, and it might be a non-healing ulcer. In another patient, it might be arthritis. Wherever the inflammation is, it can lead to a rise in systemic inflammation that we can monitor, as you will hear, with biomarkers of inflammation such as C-reactive protein, which is downstream of interleukin-6, which is downstream of interleukin-1, and give us a clinically usable tool to gauge inflammation wherever it is that can then impinge on the atherosclerotic plaque, be it quiescent and innocent appearing, or one that has given rise to a previous event. So here's, again, a different depiction of what I showed you of the T-cell committee interacting with the innate immune cell, eliciting those stereotyped responses. And here are a variety of diseases, which I mentioned, which really play out the same scenario over and over again in a really tissue non-specific way. Now, I've spoken mostly about chronic diseases and inflammation, but inflammation is also crucially involved in acute conditions, such as bacterial or viral sepsis. Now, this is where my friend, the endothelial cell, comes in, because the endothelial cell lines all blood vessels of all sizes, and it's a critical interface between the blood and the tissues. And the endothelial cell is one of the few surfaces, either synthetic or natural, that can maintain blood in a liquid state during prolonged contact. So it's really a remarkable surface. And the endothelial cell actually exhibits a Janus-like duality. Its homeostatic resting state is one that is anti-inflammatory, antithrombotic and profibrinolytic, vasodilator, and quiescent. And we understand the molecular details of those functions in exquisite detail today. But then, when the endothelial cell senses danger, and when we need to mobilize the inflammatory response in order to repair injury, repel invaders, or heal, the endothelial cell can exhibit a palette of pro-inflammatory functions, prothrombotic and antifibrinolytic functions, vasoconstrictor instead of vasodilator, and angiogenic responses. So the endothelial cell can toggle between these two characteristics. And as I say, we know the detail of many of these endothelial functions. I'm not going to go through all of this, but suffice it to say, you should all buy a copy of my book and read my chapter on the vascular biology of atherosclerosis in the Bromwald's heart disease, which is now in its 12th edition, but the reason I have gray hair is because we're working on the 13th edition now. This figure is very crude, isn't it? Look at the date, 1989. I made this with the first version of Mac Paint. Yes, I'm guilty, I'm a Mac person. And that's why the bottom of the slide is cut off. And I was invited to speak to a group of pediatricians. Okay, imagine that, an adult internist being invited to speak to pediatricians that were interested in septic shock. And I put together this figure in the paper that I wrote from this meeting, showing that when you have a bacterial mediator, and we call this a pathogen-associated molecular pattern, or PAMP, and an exemplar of PAMPs is gram-negative bacterial endotoxin or lipopolysaccharide, we can elicit the pro-inflammatory cytokines, tumor necrosis factor, or interleukin-1, and that can tip that balance of the endothelial cell from its homeostatic basal state to one that is poised to repair injury, but in the excess can actually promote disease. And so I was part of a group, we called it the 3I Club, Inflammation, Immunity, and Infection. And we had a series of meetings that were actually sponsored and initiated by Ahmed Hassan, who we invited to be part of this meeting from the NIH. And we met over a period of a decade or so. We had, at our final meeting, I was tasked with writing up the proceeds. And so this is before the pandemic. But we wrote this piece and published it in JAC. You can't see the reference, but it should be in your books. It's cut off because of this transition between Mac and PC. And we made the point that inflammation, wherever it is, can elicit DAMPs, which are danger-associated molecular patterns. When a cell dies, it can release, for example, interleukin-1 alpha. And then the PAMPs that come from an acute infection, such as endotoxins of various varieties, they can then impinge on that prepared soil of the atherosclerotic plaque and push the plaque through an episode of complication, giving a rise to the acute manifestation of atherosclerosis, a myocardial infarction or acute coronary syndromes. Now, I put this figure together before the pandemic and congratulate myself on having highlighted bronchitis, influenza, and pneumonia as a potential source of these mediators that would then impinge on the plaque. And we went through various mechanisms of cardiovascular complications during acute infections, most of which involve not just hemodynamics, but also inflammatory pathways. And I told you that cancer can also share aspects of inflammation biology in very important ways. And in this publication, I sort of lifted a figure from Alberto Mantovani, who is at Humanitas in Milano, and who really was a prime thinker in this area of inflammation and cancer many, many years ago. And with a colleague, Sebastian Kobold, in Munich, who is an oncologist and oncopharmacologist, we got to be buddies, and we recognized that we really study diseases which seem very diverse, but are really very, very complementary. And I've been an advocate of expanding the idea of cardio-oncology beyond the cardiologist coming and sweeping up the damage wrought by the oncologist with chemotherapy and radiation, but actually a biological commonality between cancer and atherosclerosis. And this is one of the more complicated figures that I've ever composed. And it states here that although up in the instigation, cancer may be due mostly to somatic mutations, or in some cases, a few cases, very well-established viral pathogenesis. And atherosclerosis we attribute to a series of very well-known risk factors. But once we get the disease going, we have the same mediators, shown here in the middle column, are involved, and those same stereotype processes, such as proliferation and angiogenesis and fibrosis, are all critical in oncogenesis and particularly in metastasis and growth of tumors. So really the biology of cancer and atherosclerosis are tightly linked, and inflammation is a common theme. So in that vein, we have increasing concern about aging, particularly in the back row of this room. And as our population ages, as we're successful in keeping people alive, it's going to be more and more a problem of your generation, of taking care of my generation as we age. And then everyone is scared of cancer. And we're all here because we share an interest in cardiovascular disease. So I want to share with you, near the end of my quick Immunology 202 survey, a new risk factor that has surfaced just in the last decade or so. And that is called clonal hematopoiesis of indeterminate origin, which is another link between cardiovascular disease and cancer. And what this involves is somatic mutations in stem cells in the bone marrow in a handful of known leukemia driver genes, and that give rise to clones of mutant leukocytes which can be found in peripheral blood. And my friends and colleagues at our cancer center were interested in the origins of leukemia. And so they took not people with cancer, but people who were apparently well, and genotyped them for mutations in these genes. And the surprise was that in a very age-dependent manner, when you're 70 years old, you have over a 10% chance of having a clone of these mutant leukocytes, myeloid cells, in your bloodstream. And although people who have these clones are at increased risk for leukemia, developing acute leukemia requires the successive acquisition of 2 more mutations in leukemia driver genes. So the big surprise was that although the transition to hematologic malignancy in those who have these clones is rather uncommon, 0.5 to 1% per year, there's a striking increase in the risk of cardiovascular diseases, and that has really opened up a whole new field in cardiovascular medicine. So here is the bone marrow stem cell gets a mutation. You get a clone of mutant cells here, and you can pick that up in peripheral blood by sequencing. And depending on different mutations, we can get an increase in atherosclerosis events. And we think that inflammatory mediators are important at certainly with some of these mutations, TET2 and JAK2. We have really good evidence that inflammation is involved in that increase in cardiovascular disease. And not only that, but heart failure as well as atherosclerosis is increased in those who have clonal hematopoiesis. And this is a big growth area, and if you're interested in learning more, come to the session, I think it's on Monday morning, on clonal hematopoiesis, where I'll give the introductory talk. So this is all very well and good to have an understanding of the pathophysiology of inflammation and its participation in disease, some of the mediators and cells involved and mechanisms. But we're doctors, and what we want to do is harness this basic science and benefit our patients. So what do we do to control inflammation? And that's what you're going to be hearing about a lot from subsequent speakers. And let me just set the stage. You're going to be hearing much more about this study in subsequent talks. And we wouldn't have been able to get this study across the finish line if it weren't for Wolfgang Koenig. And I would say that Brazil was a very important participant in this trial. It was called CANTOS, and it was the first study with an anti-inflammatory agent that proved the inflammation hypothesis of atherosclerosis. Now, you'll hear much more about this, but let me just share with you one of the pre-specified secondary analyses from this study, which targeted interleukin-1 beta with a monoclonal antibody in survivors of acute myocardial infarction who had a C-reactive protein that was above median, even when they were on all of the standard of care, including lipid-lowering therapy. And what you see in the green bars was that those who achieved a good response to neutralizing IL-1 beta, that they had an over 30% reduction in cardiovascular mortality and in all-cause mortality. So that really showed for the first time in humans that inflammation was a viable target in atherosclerosis. Now, many of the participants who were in the active arm of this study felt great. Their arthritis got better. Okay? There were fewer arthroplasties, but we paid a price, is that by neutralizing IL-1 beta, we caused some infections, including some, when you have 3.7 years of median follow-up and over 10,000 participants, statistically significant, including a few fatal infections. And so we really aren't done. We need to probe further in applying inflammation clinically in the cardiovascular arena. With Hafid Etoufela, a colleague in Paris, as part of the centennial collection of the American Heart Association journals, we put together this paper, to which I refer you for details of some of the different targets that are here. And actually, underneath this badge is a badge from a study, a clinical trial where I'm on the external advisory board that's giving rituximab to patients with acute myocardial infarction. So these various strategies are all in hot clinical pursuit. Now let me take you back to this central inflammatory pathway, which involves the inflammasome, which is a supramolecular structure that senses danger, that is involved in activating pro-inflammatory cytokines to their active form from their precursor form. In my laboratory, we showed that IL-1 can induce its own gene expression back in the 1980s. In the late 80s and early 90s, we showed that IL-1 can induce IL-6, and we know that IL-6 is a key instigator of that acute phase response, which I talked about. The actual causal mediators of the acute phase response are what I spoke about, fibrinogen and PI1. These are terrible biomarkers. Wolfgang can tell you all the problems with them as biomarkers. But a very good way of looking at this whole pathway through the glass darkly is measuring the pentraxin C-reactive protein. So you'll be hearing a lot more about that later on in this talk. And one of the questions that we're currently asking is, can we preserve interleukin-1 beta's role in host defenses, fighting infection, but diminish cardiovascular risk by going one step lower and targeting not IL-1 beta, but IL-6. You'll hear more about that later. So Beyond cytokines, there are inflammasome inhibitors. Almost every pharma and many biotechs have programs in inflammasome inhibitors. Colchicine, we can talk about the pros and cons of colchicine, but colchicine is the first drug to gain approval by the US Food and Drug Administration, FDA, for cardiovascular use as an anti-inflammatory. And then there's this burgeoning story of the incretin mimetics. In the SELECT trial, which targeted people without diabetes with a drug that was developed for diabetes, semaglutide, there were remarkable reductions in cardiovascular endpoints. So this was first thought of as a safety trial, and it turned out to be a big winner in terms of benefit. But what caught my attention in this New England Journal paper was this line, that the high sensitivity CRP in the patients who were treated with semaglutide dropped by almost 40%, a little bit more than we saw with anti-IL-1 beta in CANTOS trial. So this, to me, is extraordinarily exciting because it means we have a new angle on inflammation, and we have drugs that are currently available that can really attack inflammation as well as other aspects of cardiovascular risk and provide an outsized clinical benefit. So one of the problems is that you can't approach one size fits all, because if we're going to expose people to agents that are potentially interfering with host defenses, wouldn't it be nice if we could pick out the people who were particularly able to benefit from an anti-inflammatory intervention? And in that regard, we performed a post hoc analysis of the CANTOS trial. We designed CANTOS in about 2008. Clonal hematopoiesis was discovered in about 2014. So we couldn't pre-specify this analysis, and in fact, we only had DNA and genetic consent on a minority of the participants, over 10,000 participants in CANTOS. But in the almost 4,000 individuals where we had DNA and could sequence them and call clonal hematopoiesis, we tested the hypothesis in a pilot exploratory way that those who had TET2 chip, for which we had very good evidence involved the inflammasome IL-1 beta pathway, whether they would benefit more. And indeed, in this exploratory analysis, we were able to demonstrate that. So this is just a way forward in precision medicine and cardiology. So where do we stand now? Inflammation is a common contributor to atherothrombosis and is becoming clinically actionable. And you guys will bring it forward. Okay? And so during your professional lifetime, we're going to have anti-inflammatories, not just for atherosclerosis, but for a number of chronic diseases that may not have been viewed as inflammatory diseases. So where are we? Well, at a turning point in the Second War, Winston Churchill said, "Now this is not the end. It is not even the beginning of the end, but it is perhaps the end of the beginning." And so is my talk. Okay? So I want to make one other very important point before I close, is why is it that inflammation has bred so much resistance, especially in Europe? And people dismiss inflammation and say that C-reactive protein is nonspecific. And one of the reasons is because there's sort of an entrenched traditional epidemiology community that thinks that there's competition between the inflammatory hypothesis and traditional risk factors such as LDL, such as hypertension, such as smoking. And that is completely contrary to the whole construct of inflammation's contribution to cardiovascular disease. It's a false dichotomy. It isn't either traditional risk factors or inflammation. Inflammation provides a series of pathways, which I've shared with you in my talk, which help us to understand how traditional risk factors can change the biology of the artery wall and the plaque in a way which can promote the disease and its complication. So, of course, one of the great things in our profession is teamwork, and I wouldn't be standing here if it weren't for the work of very many colleagues and trainees. So thank you very much for your attention.